Dear Facebook Pure Urology viewers, good evening one and all. Today our topic is what the management of the stone is happening with technological advancements. As you all seen, in the last decade, significant change has come in the miniaturization of the PCNL instruments. Everybody was thinking that the perc is gone and mini perc stayed. Suddenly, the lasers have come in big way. Everybody thought Holmium laser not only for enucleation, but for the stone, it will replace the pneumatic lithotripters. Even Swiss lithoclast has fallen down. After that, suddenly RIRS has picked up in the last decade. A lot of smaller scopes are coming, and Thulium fiber laser also has come. So rapidly things are changing. Not only in this field, every field, miniaturization, less pain, less stay in the hospital is the crux. But at the same time, we are fighting with SFR. What is a true SFR for PCNL? What is the true SFR for RIRS? We don't know. So overall, the juniors who are coming into the field may not be knowing anatrophic nephrolithotomy at all, may not be knowing pyelolithotomy at all. Things have changed. So to discuss about that in relation to the technological advancements, what is the stone management going to be by a well-known academician in the field of endo-urology for stone disease, Dr. Amelia Pietropaolo, madam. You might have seen a lot of her papers and a lot of her activity from the England. Basically, last time also we had her in the discussion. So before I hand over the program to her, formally I will introduce about her in this context. So once again, the topic is stone treatment in the era of technological advancements. Dr. Amelia madam is consultant urological surgeon, University Hospital, Southampton NHS Foundation Trust. Her field of interest is urolithiasis, endo-urology and minimally invasive surgery. Board member of EU-LIS and IAU 98. Current part of editorial board and reviewer for 13 journals. Author and presenter for more than 50 abstracts in international conferences. Author of 90 publication indexed journals. Peer reviewer for 25 journals. Member of Youth Editorial Board of Journal of Minimally Invasive Surgery. That shows how fast she could achieve this. Clinical Research Award ULIS 2019 with Endo-urological Management of Stones in Solitary Kidney. Best Video Award Bowes Endo-urology 2021 with Management of Encrusted Stent. With this introduction, once again, I thank Amelia madam for joining this program. For us, good evening, and for you, I think, good afternoon, madam. Thank you for joining once again with your vast experience in the endo-urology. Today, a lot of people in India and across the Asia will be interested what technological advancements are there and how the guidelines are going to be changed with this. We love to listen to this interesting topic related to stone. Thank you. Over to you.
Thank you very much, Dr. Mohan. That's a very nice introduction. I'm very humbled by this. And thank you very much for the invitation as well. I'm very happy to be here with you again. Last time to talk, we were talking about lithotripsy, shockwave lithotripsy. This time will be more about technological advancement, as you mentioned. So yes. If you're happy, I'm going to share my slides.
Yes, please.
So we can start our chat. So I hope you can see my screen.
Yes, very nice.
And perfect, thank you. So that's the introduction. As Dr. Chandra has already said, is a stone treatment in the era of technological advancement. And I am a consultant urologist in a University Hospital Southampton in the United Kingdom. And I'm part of European Urology Association and British Association of Urological Surgeons. And let's go through just to show you my conflict of interest. And then let's start our presentation. So unfortunately, kidney stone disease is a disease that is getting worse over the time. We have many more patients due to of course, the diet, different countries, environmental factors as well need to be taken into account. And unfortunately, this also is very affecting our economic burden in kidney stones, as kidney stones disease is sometimes more costly than other diseases, for example, prostate and bladder cancer in many states and countries, including the United Kingdom. That's why we need to really keep a look and see how we can improve the treatment of stones for our patient and have an effective outcomes. And there are many advances in ureteroscopy, but also in PCNL, and we will see it later. I will start to discuss about ureteroscopy just because in the last few years, there's been many technological advancements that have increased the way we treat stones and patients, of course. And for example, advancement in the irrigation device, in single-use scopes, new lasers devices, better vision, advance of pulse modulation, and what we can do with simulation and robotic assisted system. And all these allow us to create a tailored endo-urological stone treatment, which can be tailored on the patient characteristic, but also on the stone characteristic. So everything is very important to get the better outcomes. And let's start with what's new in the ureteroscopes. And as you can see, there's been a lot of advancement in the last years, in the last more than 20 years, because when we started with rigid ureteroscopes, fiber optic, and then we got to flexible ureteroscopes. And now more recently, what changed in the last 5 years is that we have single-use ureteroscopes. There are so many of them now in the markets. All of them have been launched in the last few years, and they are extraordinary in terms of characteristics and features. They've been studied in vitro and vivo studies, and more or less the characteristics of them are similar. In particular, the weight, the shaft size, the deflection angle are all very similar. So the studies have been done, as we said, ex vivo. They've all been compared, and more or less similar and comparable have been between LithoView, PCNL, and Axis. And then what they've been really compared in benchtop studies was optical characteristics, handling, and clinical performance. And we found that are very comparable to the reusable scopes. And also the optic characteristic and of course, they're all digital scopes, and the vision has been compared in between them in vitro analysis for the four different scopes. And you can see how the view is amazing for most of them. And there is not a real best one, because when the vision is not as good, there are other characteristics that can compensate. And why would you choose a ureteroscope, and why would you choose to have a single-use ureteroscope? First of all, I will talk about myself. Sometimes reusable scopes are very heavy because you need to attach the camera, and with the long procedures with hard and big stones, you will take a long time to do the procedure, and this will be very much affecting your fatigue and your ergonomics. So having a lighter scope, like a single-use scope, helps in this case for less muscle workload, but not only. Also durability, because reusable fiber optic scope or digital scope get damaged very often, so they're very prone to breakages. So they need to be repaired, be sent for repair, which is very costly, but also takes time to come back. While the single-use scope, they're always brand new. And reprocessing and sterility. So as you know, the reusable scopes need to be deserialized, and sometimes can happen. And unfortunately, despite that, there will be still some bacteric colonies that are ongoing and surviving to the decontamination. And this can increase the risk of contaminating a patient who might be already very comorbid and high risk for infection. So, of course, when we consider a single-use ureteroscope, we need to take into consideration the costs, which is very important in European countries, but also in Indian countries. And when we take into consideration the cost, we also need to consider the micro-costing analysis. And this includes not only the purchase of the scope, but also the fact that when you buy a reusable scope, You need to buy the monitor, of course, but you need to take into consideration all the steps of the decontamination with all the disposables that they use to clean, including the detergents, the soap, and all the disposables they use for that, including the many people involved in the reprocessing work. Leak testing, manual cleaning, draining and storage, repairs, if of course needs to be repaired. All these needs to be taken into consideration for a reusable scope, while a single-use scope, nothing of this needs to be taken into consideration because you just bin it after the use. Also, as we said, it takes time to re-sterilize. The pre-cleaning, manual cleaning, rinsing, drying, storage, all take between 90 and 150 minutes, all in all, which means that you need to wait until your reusable scope will be ready, while your single-use scope will be just open it and use it. So there's no time in between. And also, time, of course, time is money. And so what we have analyzed over the many studies that have been done about microcosting and repair rate is that actually there are many major repairs and higher repairs for digital flexible ureteroscope. And maybe if you consider that, you can avoid to use a reusable scope, and instead you can use a single-use scope, which despite is more expensive, on balance, the price will be the same. And this is some example of the scopes that are on the system in UK. We normally have two main types of scope. We have the LithoView from Boston Scientific that have some devices that can be attached to it. For example, this is the LithoView empowered device that allows the operator to remove the stones on his own without asking an assistant to open and close all the time. So you can see the index finger will open and close the basket. And this comes with the scope and can be attached to the handle of the scope. But also they will launch soon, hopefully, the smart package that includes a lot of other systems that speak to each other. And we will talk about this in a second, to decrease the intrarenal pressure, improve the view, and also to have a smart system that is all in communication. Other scopes in the market can be, for example, the PCNL scope from China. This is also an excellent scope in terms of vision. They have recently improved the HD system, so the vision is much better, but also they've launched a smaller scope, so it's 7.5 French, so it's very, very thin. And as you can see, you can use it in pediatric cases, in case with ureter is a bit narrow, and when you need the better drainage, which in turns decrease your intrarenal pressure because you have more space, as you can see in the right side, between the scope and the access sheath. So your drainage is better. And you can see this is the new image processor that was mentioning before, which increased the view much more than before. So in terms of single use, again, there's the PCNL one that I've just shown you. And of course, for single use versus reusable, there are advantages and disadvantages, as everything. So advantage will be that it's always available. There is a brand new scope, which every time an optimal deflection, because this happens also over the time of usage of a reusable scope. At some point, the deflection is not as good, so you need to send it for repair. While with a single-use scope, disposable scope is always brand new. And also, and this means that you can also use it for difficult case when you are actually risking to break the scope, because you know that it doesn't have to be repaired. It's just, you can just throw it away after. So you can select the cases where you want to use it. On the other hand, unfortunately, it's a single-use scope. It's a lot of plastic, and therefore you need to consider the environmental impact. But companies like Boston, in this case, or Coloplast, they're trying already to reduce the carbon footprint related to it. And there will be also a very specific program or reprocessing the scope to make other things from the plastic, which we will see in the future. And this hopefully will help the planet health. And of course, there are many papers nowadays about disposable scopes, and the conclusion is always that it can be used successfully. And there are many factors that be considered when deciding which best is a scope to use, and needs to be considered, of course, the cost-benefit analysis before making the decision. So how you make the cost analysis is different in every country. So this is what they've done in other countries like Australia, in other states of the US. And also, and of course, you can see the cost analysis always shows how that the single-use scope is actually cost beneficial if you use it in high volume center. And why is this? I just wanted to explain the concept of the hybrid model. And this is more or less what I said before. If you can study your cases and understand in which cases you think you will cause more strain and more increase of damage of your reusable scope, you can try to avoid using a reusable scope in those cases and instead use a single-use scope. This increases the longevity of your reusable scope to 40%. And I will explain you why. You can see that using hybrid systems, so using a single-use scope rather than a reusable scope in complicated cases, increase the time span between repairs. So the number of repairs of the reusable scope in total decreases. And in turn, this on balance has a cost saving for your hospital. And in fact, I wanted to show you what we do. In Southampton, in our shelf, we have normally reusable scope. We use it for many straightforward cases, cancer cases, small stones, patients with low risk of infection, straightforward. But when we have complex cases, we use single-use scope. And for example, when we have a large stone burden, so we need to stay there for a long time, you don't want to spend long time in a kidney with a reusable scope, you prefer a single-use scope for less infection risk, where you know that the steep infundibulum pelvic angle is the angle is very steep, so you might break the scope if you bend too much. And in this case, single-use scope is excellent. And then, as I said, when you have narrow ureters, a small ureter, you can use a small single-use scope like the Busen or the HugeMed. And when you do an endoscopic combined intrarenal surgery, when you risk that actually the other colleague might break your scope with the laser, you can use a single use. Of course, cases of complex anatomy and cases when you have a trainee that is not very experienced, you don't want them to break a reusable scope, which is sensible, and you can still decrease the cost for your hospital. This cost analysis has been done in many other countries, and the hybrid use of a single use and reusable scope seems to be best compromised from the medical economic point of view in high volume centers. This means you have to have a lot of cases and have the capacity to afford both in order to choose which is the best case for single use. And how do you choose the right single use ureteroscope?
Yes.
You can of course need to consider the cost, as we said, and the cost depends on how many scopes, how many reusable scopes you break, and what is your deal with the company? So what's the warranty you have on your reusable scopes? But also the usability, which one you prefer, the personal relationship with the company, but also what you see around you in the literature, in the outcome that other people say, and in the literature, and in the social media influence. So what does the future hold in terms of ureteroscopy? Probably the market will become more competitive, and there will be a decrease of the cost for the disposable scopes, we hope, so that it will be affordable for every hospital, every country. And you can see how it's already getting on the right way, but hopefully this will be improving over the time with the technological advancements. What we have in the future is also having hybrid scopes. So this is not the hybrid model, but it's a hybrid scope. You have a rigid ureteroscope that has a flexible tip that can be maneuvered with your handle. It's a rigid scope, but you can bend the tip like in a flexible scope. So this is a scope that has both characteristics, flexible and rigid at the same time. So what question mark, can it be cheaper? Or so that you don't have to open two scopes for procedure, but you just need one? We don't know yet. There are not many studies on this, but this has been launched recently by Wolf, and we want to know what's happened in terms of this in the future. Other technological advancement in ureteroscopy is robots. So we've been talking about that for many years, and you remember the Avicenna robot, which you can sit far from the patient and manipulate like a real Da Vinci robot from a little handle. And then they have recently introduced the Ely robot. There is like a video game controller that also allow you to maneuver your flexible ureteroscope that is inside the patient, far from the patient, so that you avoid the strain that on your wrist and on your muscles. But again, this is not something that we can use every day because of the high cost. And to be honest, the advantage of this has not been 100% proven yet. So it's some food for thoughts, I would say. Let's go now to what we really like, lasers. So what we really prefer to talk in endo-urology is the innovation about lasers. So first of all, we have on one end our best gold standard Holmium YAG laser, which in the last few years has been enhanced from low power generator to high power generators that can reach a power much higher. And on the other hand, we have the new kid on the block, which is the Thulium fiber laser. Let's talk a bit about both. So let's start with the Holmium YAG laser. As you know, there's been a lot of discussion recently about watts. So do we really need a high power laser for treating of stones in the RIRS? One team says yes, some other team says is not essential. So what is the actual answer? We have done some studies on our patients. In our settings, we see how high power laser or mid power laser can reach better results, mainly for bigger stones, because can have a low operating time, a shorter operating time, which of course decrease the complication and increase the efficacy and the outcome of our procedure. And we have published our study. This is actually quite an old paper because we started using high power laser 4 or 5 years ago. And you can see how we already started to treat large stones bigger than 15 millimeters with that. And you can see even if we didn't have a high number of patients, which we've now increased to more than 200 in the next paper that we're going to publish next, the outcomes are very good because the operating time doesn't go beyond 51 minutes, which is excellent, and the stone-free rate is also excellent. And of course, with this laser, we use a pop dusting settings, which has a high rate, about 40 watts in total, and with normally 0.5 and 40 or 50 hertz, which allows good pop dusting and can allow complete stone clearance of very large stones, even bigger than 15 millimeters. We've also tried to compare our results between low power laser and mid power laser in Holmium YAG, of course. And for this, we use the Luminis or Boston Scientific Moses 60 watt laser that you can see here. As you know, pulse modulation, so Moses technology has, of course, changed our way to treat stones because of the way of reducing lithotripsy and increasing the effectiveness of our laser lithotripsy. And you can see in our results how with 60 watt laser, which would be group A, we have much less operating time, with similar size of stone. And stone-free rate is also better, with less need of a repeat procedure.
Yeah.
Many other people have talked about pulse modulation and Moses over the time. And of course, there's a lot to say. Some groups say that there's no difference in using Moses or non-Moses, of using new generation of pulse modulation. In our series, we see that there is actually a difference, and this is mainly in the time that you need for the lithotripsy. I wanted to show you some videos about how high power laser, in particular Moses technology, works for big stones. And this is our case, a very short clip, but it's a very big stone. So of course, this is an edited video, but you can see how at the beginning the view is not great. This is a digital scope, and immediately we can break the stone into big fragments that then can be completely disintegrated with a pop dusting effect. And at the end, the dust is very, very fine and can be just flushed away through the access sheet. And that's a Holmium YAG. Let's go and talk about Thulium fiber laser. We've been hearing about it for the last few years, and this is a great technological advancement because it can allow to have higher speed of ablation efficiency. Stones, dust size is much finer, is much smaller, and also there is less retopulsion, and the fiber itself is much smaller than the Holmium YAG, which will improve of course, the irrigation, and so your view is better. So let's say that globally, we can say that it has a higher pulse frequency, lower pulse energy, less retopulsion, it's faster, the stone dusting is more effective, it's a smaller device, and it's a plug and play. So it doesn't need a big plug socket to be installed, but it actually can use a normal plug, the one you have at home as well, for your hair dryer, and it's less noisy. So you see that the Holmium YAG is very noisy. Well, with your Thulium YAG laser, you can actually play music in your operating theater, which is very good. There's been some studies to compare the efficacy of the Holmium YAG laser and the Thulium fiber laser in RIRS. And this is a randomized clinical trial, the first one that was done in the Norway study. And you can see how Thulium fiber laser, has a better outcomes. However, we're not very convinced about these results just because the sample is very low of the patients initially, and also the Holmium YAG laser that was used here was not a high power laser, but it was at 30 watts. So maybe I would say we can have a better results if you use a high power laser, as we discussed before. And these are the results. Overall, there's a good stone-free rate and no adverse event or complication for the Thulium fiber group, or at least no difference. And new paper that has been just published a few weeks ago, February 2022, is 2023, sorry. This is in Journal of Urology, and it's again a randomized trial between Thulium fiber laser and Holmium YAG laser, and it's prospective randomized clinical trial on 180 patients, 52 in Holmium YAG and 56 in Thulium fiber laser. The main difference is actually the length of ablation time and the ablation speed, which is similar for the both groups. So you see that the pulse modulated Holmium YAG laser has less total energy compared to the Thulium fiber laser, with an improved ablation efficacy compared to the Thulium fiber laser. And there is no different complication rate. And also there is a comparable stone-free rate that was observed between the two groups. For those with no residual stones fragments, 3 millimeter or 0 stone fragments, you can see a difference here. No difference in total stone-free rate was detected mainly when dividing the cord by stone location or imaging modality, as you can see in this table. So this is a very interesting paper. Essentially, in comparison, it just says that there is no difference whatsoever between the two if used properly with similar size of stones. I can show you a comparison, and this is how I showed you previously a video on Holmium YAG. This is a video of TFL. You can see on the left side how is the beginning of the fragmentation starts. Actually, the characteristic of the Thulium fiber laser is that there is no fragmentation. So you need to set up your laser in order not to charge the stone, because the pulse energy can create this burning effect of the stone. But if you actually get the settings right, that's on the right side is what you achieve, a very nice whirlpool effect of pop dusting, similar to the one we can have with Holmium YAG, but the dust is much finer. So carrying on, we don't know the right setting for Thulium fiber laser. Of course, everybody has his own favorites, and that's what my colleague Etienne Keller tried to sort of summarize back in the beginning of 2022, when we really didn't know much about different in renal stones, ureteric stones, total duration, pulse duration, and global watts that you would use in Thulium fiber laser with small fiber and bigger fiber. So I think this is very interesting, but clearly many things have changed since, and everybody might have a different view in terms of what's the best setting for which type of stone. So another innovation in laser is this. This is a Thulium YAG laser. So it's not Holmium YAG, it's not Thulium fiber. It's a different solid laser. It's not a fiber laser. It is a continuous wave laser used mainly for tissue resection, vaporization, and nucleation so far. So it's the one that we used for tulip before, but it's now also used for stone. And you've seen in the video how it's a very nice dusting effect. And in fact, as you can see in this little summary, there is a 4 times faster stone dusting, less retropulsion, 2 more peak power than Thulium fiber laser, and avoids irrigation overheating. We don't know much about this, to be honest, because at the moment, there's still no data, no studies on it, but we will definitely see it more and more often in the future. So I just wanted to mention to you, to tell you there is a third laser on the market. Just wanted to show a short clip. This has been done with a Holmium YAG, And you can see how even in difficult cases, so pediatric patient, cystic stone, big stone, the Holmium YAG is still a good alternative for in this case, and you can use you can achieve a very good lithotripsy effect at the end. So what does the future hold in terms of flexible ureteroscopes? We've seen single-use scopes, we've seen many things that have changed over the time. What we need now is suction capability and pressure sensor, improved irrigation, probably also artificial intelligence. We will see something in the next slide. So starting with intrarenal pressure, what does it actually mean? Does it really matter? There's been a lot of study ex vivo to see if this really matters. This is a phantom kidney where they've measured the pressure inside, but unfortunately this is an ex vivo model, so we don't actually know. Many studies have given tips and tricks to how to reduce the pressure, how to reduce the temperature in the kidney. But again, this was done in ex vivo models. So what we know so far is that intrarenal pressure is really something, because we know that we need to keep our intrarenal pressure below 40 millimeters of mercurium if we don't want to cause all this, which means increased pressure in the cavities, which increase the risk of pilovenous backflow. So beyond the 40 centimeter of water, we have increased pilovenous backflow and risk of fornix rupture. So we can have perineal hematoma. This has been shown in many studies. And of course, the prevention has been, of course, to reduce the heart rate, the blood pressure of the patient, but also reduce your intrarenal pressure. You need to reduce your operating time. So you need to be very aware of what can be the complication of working with a very high pressure. And pressure matters, as has been shown in many papers over the last few years, since 2018 to now. So we are starting querying, what can we do to reduce our intrarenal pressure when we really need it, when we really need the better irrigation? So we know, we said about the pilovenous backflow. What does it mean? If there is a higher intrarenal pressure, there is a more higher fluid reabsorption, which in turn can increase the risk of sepsis and also the pressure damage inside the kidney. So the threshold is 40 centimeters of water, which should be the goal during the endo-urological procedure. But of course, we don't know how to measure it. So what we can do so far is try to decrease our irrigation. And how we can do that is to improve the drainage. So reduce your irrigation pressure, improve your drainage, to in turn reduce the intrarenal pressure. So access sheath is always very useful for that. And you can see that all the difference is the gradient between the access sheath diameter and your scope. So the more is this gradient, the better is your drainage, and therefore the less is your intrarenal pressure. And there's a lot of studies to say what's the best access sheath and what's the best ratio between scope and access sheath. And we have studied this in our patients, and this is our outcomes. We've seen that in 7-year periods, in patients with a very high stone volume, and the operating time using the access sheath was slightly different, but actually the complication rate with patient with access sheath was much less. And again, as I said, how do we prevent to get this intrarenal pressure? We need to concentrate on your irrigation. Irrigation devices have been studied over the time. There are many different brands, many different devices. Of course, there are manual pumps, foot pumps, continuous irrigation, pressure bags. And there is a study that compares in vitro different irrigation devices, saying what are best, what are actually not to use. So I would suggest to read this paper if you're interested. This is what we have used in the last few years, and this is the transfer flow by Rocamed. This allows a steady liquid flow during irrigation, and also an aspiration that gives improved visibility. You can see what gets attached to your ureteroscopes, and it can increase the pressure with a manual pump that is also controlled. And the pressure is all the time indicated in the machine, and theoretically is identical to the pressure inside the renal cavity. We don't know that, but I will talk about this later. So what else can we do? We can decrease the size of our ureteroscope. As I said before, with a 7.5 French ureteroscope, you can even use a small access sheath to still have a good ratio and gradient between your flexible ureteroscope and access sheath that increase your irrigation and decrease the drainage, and therefore also decrease the intrarenal pressure and improve your visibility without having too high intrarenal pressure. And as I said, you can select which scope to use according to your ureter and according to the risk of infection. So if you know that your procedure will be long, you have a large stone, difficult to reach, maybe you should use a single-use scope and a smaller scope, which again will decrease the intrarenal pressure and the risk of sepsis in your patient. But as I said, we know how to decrease your irrigation to control our drainage, but we don't actually know how much is the pressure in the kidney, because so far we didn't have any way to actually measure this. So how do we monitor the intrarenal pressure? There are many new technological advancements in that, and in particular, we have pressure sensors and suction devices that are new. Pressure sensors, you might have seen this on Twitter. Professor Traxler has just published this paper on a real-time intrarenal pressure control during flexible ureteroscopy using the vascular pressure wire. And this is a pilot study. You can see the pressure wire is a vascular wire, so it's not something inside the scope, but it's something that goes inside the kidney independently. You can see in this picture how it can be outside the access sheath or inside the access sheath. And essentially, they've trialed it in 20 patients to see that, of course, it doesn't change anything inside the procedure, but it can allow you to measure your peak pressure and your pressure during the whole procedure, seeing when you manual pump your actual irrigation, you can actually reach very high peak pressure inside the renal cavities, which can be risky, as we said before. In fact, they reached 61 centimeter of water, and the maximum one was 238, which we didn't know before, and now that we can measure, can actually avoid it. These are what their outcomes. Of course, they didn't find any postoperative infection more than normal in these patients, and you can see how they have used it in live. You can see how in the graph in the bottom, they measure real time the pressure inside the cavities while they pump the irrigation. So you can see how you can reach a peak of 49 or 50 centimeter of water during the procedure. And yeah, just to show you again, that was on Twitter just a few weeks ago, in case you're interested, from Professor Traxler. And they've used it also for urothelial cancer, which we're not going to talk too much about, but again, it's interesting that you can use it in both cases. But what is really new is that this pressure sensor, or there will be new pressure sensor that will be integrated inside the flexible single-use ureteroscope. And this is the real new thing. This has been already trialed in Canada, is being launched by Boston Scientific, and in these scopes called there will be some other characteristic. You can see this video is about how the scope can measure the intrarenal pressure in millimeter of mercury, in this case, during the lithotripsy. So you can see the laser is activating and you have an irrigation running, and you can see the signal that says you're actually having too much pressure real time, so that if you want, you can decrease your irrigation, and or the system can actually tell you when the irrigation is too much or the pressure is too high, and you will decrease the inflow itself, which is part of the smart package that Boston Scientific is going to give us. And we talked about the pressure sensor. Now we will need to talk about how we can have suction device, which can decrease the intrarenal pressure, but also can allow us to have a better stone evacuation technique and better vision. They've talked about these suction devices in rigid and flexible ureteroscopes. This is, for example, an access sheet that was described by the Chinese group in 2019 and 2018, and it was attached to irrigation suctioning platform. Also, there is something attached to the semi-rigid and rigid ureteroscope, which was a negative pressure lithotripsy, which improved the outcomes as well. This is the new paper that published with Vineet Gawar, and you can see how in this case they apply a direct in-scope suction to improve the outcomes of the RIRS. And this is a video that, of course, is being given as a courtesy by Vineet. You can see how you have a lot of dust inside the kidney, and when they activate the suction, you will see clearly how all these little debris and fragments will be aspirated through the scope channel. So you don't need another device, you don't need another sheath or anything. This goes into the scope through a different, through the working channel. And this is what they've found in their result. Actually, they've seen a few patients, and they found that the surgical time is, of course, better when you use a suction, because it's obviously you don't have to go in and out to remove the fragments by yourself, one by one. And the residual fragments, mainly the difference is in global large residual fragments. The stone-free rate is similar, but there are less number of residual fragments in the case when you use suction device. And these are other suction devices that they have been launched recently. These are mainly ex vivo studies tested, in vivo studies tested in 278 patients by the Chinese group. And this is in 444 patients. This is a suctioning access sheath that enables higher stone-free rates and better infectious complication. So there, I'm sure we will hear much more about this in the future, and that's what they're already using. This was on Twitter a few days ago, and that's how it works. So there is a continuous suction that can be increased by a suction device through the scope. So we've talked about pressure, we talked about suction, irrigation, temperature. We have mentioned, we don't know much about it, but there will also be temperature sensor in the same scope. They will have pressure sensor. This is a concept, the smart package that will be created with the LithoView Elite soon. And potential features that will be applied to technological advances applied to flexible ureteroscopy is also allowance to check how many fragments you have left, the density of the stones, is this the distance between the stone and the tissue, the volume of what's remaining, but also the trajectory of the fragments. And all this can be implemented by the artificial intelligence and can increase the control of the surgeon and the efficiency of the stone removal. So the future of ureteroscopy is actually very wide, and there includes temperature control, multi-axis deflection, sustainability, artificial intelligence, and wireless control. Who knows in the future? So potential capabilities, you can see here, this is a prototype when you can see in a video how at the same time you can see how many particles of stones you have, where they are, how big they are, how much flow is flowing inside, what's the pressure, and so on. That's the ideal scenario that we want to see in the next future. So as I mentioned, future of ureteroscopy is unwritten. Let's do a brief mention about upper tract TCC. Of course, they're not the aim of our talk today, but I just wanted to show you how technological advancement can allow us to manage low-grade TCC without having a complete nephroureterectomy. So guidelines now consider that for low-risk upper tract cancer, less than 2 centimeters, you can still do a organ-sparing surgery, which means flexible ureteroscopy and ablation. And there are many studies saying about the outcomes, which are good. Of course, the follow-up needs to be strict. And there is a strong recommendation from the guidelines for offer kidney sparing management as primary treatment in low-risk tumors. And what I just wanted to mention is how thulium fiber laser is becoming the best in this case, because there's been described how the management of the ablation of the tissue is very good, in particular for upper tract cancer in thulium fiber laser, which we have discussed before for stones. So that's something to bear in mind. We've talked about flexible ureteroscopy. We're now going to start to talk a bit about PCNL. So what do we do for big stones nowadays? What are the technological advancements? And how Dr. Mohan has already mentioned before, we've talked about mini PCNL that we thought was a technological advancement. And in fact, this has stayed and is now one of the gold standard for stones larger than 2 centimeters, together with RIRS or Lithotripsy, according to the guidelines, but the gold standard is still PCNL. So Mini PCNL, there's been a lot of discussion about using it also for staghorn stones or for stones bigger than 2 centimeters. And in fact, there are many papers saying how you can use it for complex stones with excellent operating time and stone-free rate. And what is mini PCNL? So essentially, it's everything below everything below 20-22 French. You can see how beyond 9.5, you have ultra mini PCNL, 11 to 13, super mini, mini micro, or micro PCNL. Within the mini PCNL, you have 3 different sizes that you can choose according to the sheath that you want to place and the stones that you want to treat, which is small, medium, and large. And this is traditionally used traditionally sized between 14 and 22 French, as I said, and the indication for mini PCNL includes stones bigger than 2 centimeters or lower pole stones bigger than 1.5, renal stones that were not responsive to ureteroscopy or lithotripsy, stones in cardiac diverticulum, or complex stones in difficult anatomies, but also large impacted proximal ureteral stones. I don't want to talk too much about PCNL because, of course, in India, you have a better experience than us in Europe because you see a lot of large stones. However, these are important things for mini PCNL is that you can use it also for impacted proximal ureteroscope. That's not sure why, but we are seeing much more often since COVID. PCNL positioning, as you know, it can be prone, supine, or can be split leg, and we will see why in a second. And procedure steps is, of course, initial ultrasound guided and X-ray guided if you want to do both. Needle puncture, avoiding, of course, surrounding organs, access to the kidney, and then we can use occlusion balloon from below in order to dilate the system. And then, of course, dilatation can be done with different techniques. It can be done one-step dilatation in case of mini PCNL, or can be done with amplats and balloon. And once you are in, of course, you can use mini nephroscope in terms of mini PCNL or a normal nephroscope if you need a standard PCNL. Type of lithotripsy change, and actually we have many technological advancements in this, and that I wanted to discuss with you. In fact, energy devices, this is an old paper which show all the possibilities, and laser was already mentioned then. And but you can see how new technological advancement in the different fragmentation devices are now on the market. We have Trilogy from Boston and EMS, and this is excellent because it can combine ballistic, ultrasound, and suction effect, but also has different size of probes. So you can see how the smaller probe can allow you to do mini PCNL as well. So the efficacy of this has been compared, and the stone-free rate is 96%, and is better than thulium fiber laser at the moment. And you can use the mini PCNL, as I said, because the probe is very small. Talking about laser, we've talked about this a lot. You can use both Holmium YAG or TFL for your mini PCNL tract. And there's been a lot of discussion about what's best. And actually, we can see how the mini percutaneous with Holmium YAG laser high power is still superior than thulium fiber laser. Probably because we haven't used TFL enough, but also because it does much more, and maybe mini PCNL, you can fragment and have vacuum cleaner effect, which is much more effective than dusting sometimes. And as I said, retrieval of fragments in mini PCNL can be done with vacuum cleaner effect. And this is an example of how this works. So you don't need very small dust, but actually the big fragments can be drained spontaneously through the sheath, thank you to this Bernoulli effect that can allow your irrigation water and your fragment to follow the nephroscope and come out on their own without any basket or grasper. What else can be done in mini PCNL is suction devices. We've seen some in ureteroscopy, but this is actually something that we use daily for mini PCNL. This is the clear Petra sheath. So instead of using a sheath of mini PCNL, you can use the clear Petra sheet, which is 16 French and has a parallel other branch that can allow a continuous suction through this little negative pressure little box, essentially. So we see there are many papers comparing this to the traditional PCNL, saying that this can offer better vision and a continuous evacuation of the little fragments. And there's a lot of comparison between different suction-assisted devices, showing how, of course, the suction effect is better and the stone-free rate is better. They've also increased the suction effect using a double sheath vacuum suction, but this is still this is still not used in clinical practice, at least. I haven't seen it yet, so we'll see how it works. Fragments retrieval, we're not going to talk about this, but clearly that's something you can use in your PCNL as well to improve your stone-free rate. But how do you manage the proximal ureteric stone? As I said, we see many of these impacted stones. You can't go from below because it's completely impacted. The mucosa is very, very edematous, and you cannot go beyond with your ureteroscope from below. So sometimes putting an access sheath from above will allow us to access the stone and to treat it with a flexible ureteroscope and laser. So I just wanted to show you this case. This is not a proximal ureteric stone, but it's a stone of a ureter that is with a stone impacted just at the junction between the ureter and the ileal conduit. So this patient didn't have a bladder. So we had the best option was to go from above because the patient already had a nephrostomy. And you can see how the fragmentation is done, and the most fragments can be removed with the basket effectively, but the other fragments, because after that there is just the conduit, can be just flushed out and will be passed automatically inside the conduit. And we've seen how this technique can be effectively compared with very good outcomes and less overall complication to the laparoscopic ureterolithotomy to remove big stones. So how we can see PCNL, mini PCNL is still great, and as Dr. Chandra actually mentioned, is still something that we use every day and is part of our technological advancement thanks to the new fragmentation device like lasers and Trilogy or shock pulse, sorry. RIRS is something that has been created in Europe, has been shared and spread in the last few years thanks to Scofone and Cecilia Krakow work. This is something that is very used to treat complex stones in multiple cavities, so in different calyces. The position is a split leg position, Valdivia modified Galdacao, and allows, of course, the access to the side for the PCNL puncture, but also the access from below for the ureteroscope. And you can see how you can treat with that large complex stones and large calculi. And you can see the flexible ureteroscope goes from below, while the other operator works a mini or a standard PCNL. So the stone can be treated at the same time. And this is a video from our center. You can see this is the ureteroscopic view, and you can see that the ureteroscope can see the other colleague taking the stone. So this is the technique of passing the ball. So the one that has better access can take the stone and the other can treat it or remove it. So there's a very good teamwork, and you can see that at the same time, the other colleague will see the PCNL view and will see what the ureteroscope is doing at the same time. This is also very useful to do the endoscopic endo-guided puncture, so that you reduce your fluoroscopic exposure, and you can do an endoscopic guided puncture, so the flexible ureteroscope will help you to find a better calyx for your puncture. So that's very helpful and very good results, and you can see in this video, little videos, and that you can also use TFL for this. And the one on the left is actually the ureteroscopic view of what the PCNL is doing, and on the right you have a vacuum cleaner effect of removing the stones from the PCNL tract. So you have a very nice combined approach that allows you to decrease the time and also to get the patient stone free in one procedure, because if you had to do only one PCNL, maybe the patient had to come back for some stones that were not reachable from your tract. And all that we've discussed so far will decrease your outcome, will improve your outcome, will decrease your operating time, improve your outcomes in terms of stone-free rate, but also reduce your complication. And because you use laser, you use new technology, you can do it in patients with coagulopathy, morbid obese, foreign bodies like encrusted stents, very hard stones in pediatric patients or very difficult stones to reach, like in calyceal diverticulum or urinary diversion. I think it's important to mention what's new in our indispensable work tool. So disposable tools. We've talked about disposable scopes, but actually every day we use guide wires, retrieval devices, access sheet, suction devices, laser fibers, stents, irrigation devices, and you need to choose them according to what you prefer. We normally start with the sensor guide wire, for example, in our flexible ureteroscope, because the initial tip of the guide wire will allow us to navigate every type of ureter and go across every stone. But everybody has his own preference, and this also is the same in terms of retrieval devices. You need to consider the wire number, if you use it yourself or your assistant, the size and the type of tip. So there are many types of retrieval devices, and of course the choice is, again, depends on the relationship with the company, what you use normally, what you're more comfortable, what other people say about it, and what's the cost. So in terms of baskets, there are different tips, there are different lengths, different size, the external sheath, and so on. They need to be less than 2 Charrier or French, and normally it's less than the laser fiber, or similar to the laser fiber. They need to go inside a 3.6 Charrier working channel in ureteroscope, in your flexible ureteroscope. There are the difference in the tip. We prefer the last one, which is the 0 tip one, and many brands do different name, but same concept of basket. So you don't have to decide your brand. You can actually need to decide what you prefer. What is really new is probably this one, which is a basket that is slightly smaller. So it's 1.9 French. It will allow you to put in the working channel, not only the basket, but also the laser fiber. So you can grab the stone and treat it with the laser at the same time. So it's more versatile. Other news is this parachute concept of the encompass basket. I think it's by Cook. You can remove many fragments at the same time, thanks to the fact that the wires are very small, and it works as a parachute concept. And this is a bit more expensive. When you know that a big stone, you will have a lot of fragments. It's a hard stone. Probably this is better, unless you have a suction device, of course. And what if you have an assistant that has to do many other things while you're working and you want to be independently using your basket? You can use this. This is the Empower device by Boston. You can attach it to the handle of your UltraView, and your Dakota basket can go inside it. So if you're in that finger, you open and close the basket yourself without asking open and close all the time your assistant. There's no different in price, can be actually given with the scope, and you can see how it works here on the left side. This is very easy to learn. There's no learning curve. It's just easy. Clearly, sometimes you prefer to use the same company for all your things, like you use the scope of the same company to the basket, to the access sheet, but there are some disadvantages. They're not open to innovation. You're not stimulated to change. You don't know what's around you, and it is not cost effective. So you need to look really what's on there. Also in terms of access sheet, because there are many new in the system. Some of them can give you the suctioning effect, and as I said, we found that using access sheet can give you better outcomes, but you need to choose the right one. Just a quick mentioning about stents. There are many different stents in the market. There are a lot of also studies to know which one are best, and you can choose them in terms of comfortability for the patient, but also how firm they need to be. If they need to be allowing to drain the urine for an extrinsic compression from cancer, or it's just a stone. These are magnetic double J stent that can be removed with a magnetic removal. I don't know if they're very, very popular, to be honest. These are silicone, and the soft end in malignant cases can be more comfortable. People who have to have a stent for a long time. These are biodegradable stents. They are 100% degradable in 10 days in the urine. Do they really work? Not sure, to be honest. We don't have too much studies, so I haven't tried them, but they're new. Ureteric stents, material is important. As you can see in this case, you can have very much harder stents that can resist to extrinsic external compression caused by cancer that grows outside the ureter. So that's something that you can choose in case you have these specific cases. And metallic stents. So we have the resonance, the memocath, the Holmium. They're all very helpful in benign and malignant ureteric obstruction, mainly benign, I would say. Everyone has their pros and cons. Everybody has a learning curve. So I would say go and read a bit more about it. And in this systematic review, there is some comparison between them. Last one is the J field. You can see here how most of the stents is a single J, and the rest is just a string that hangs in the bladder, and there is no discomfort for the patient because there are no bladder symptoms. There is nothing in the bladder, and this can be removed as a normal stent with the string through a cystoscope. Some studies about it, and I would invite you to try it and see if this is more comfortable for your patients. It's been seen that between all different materials of the stents, the one with silicone are a bit more tolerable, and also they get less encrusted long term. And this, of course, sometimes they are a bit more expensive, but you can consider in patients who need the stent more term is actually more efficient. We've already talked about irrigation pressure, which I already tell, and I'm sorry if I have gone a bit beyond the time, but it's my last slide. I just want to thank you, Pure Association, and Dr. Chandra for, again, inviting me for this very interesting and great opportunity for me. Thank you very much.
Wow, wow, wow. I used to listen this from Oliver Traxler, sir, without taking breath. I think your breath holding capacity should be good. Its last 10 minutes voice was cracking. Otherwise, you're on. For any junior across the world, this video presentation with this link shows how much command on the subject, how much research along with Bhaskar Somani sir you people are doing. Fantastic, amazing research work. Now I quickly go through the common questions we face. Quick fire, there no need to explain. Quick 1-to-1 fire. Generally, people like this last part also, where we commonly see. Number one, in your last 5 years of practice, are you happy shifting towards disposable scope, using only one time, taking all the insurance and non-insurance patients into consideration, apart from your Southampton protocols? Leave apart the protocols. You have choice of both. You will pick up disposable slightly more nowadays.
Yeah, that's a very good question. And you need to take into consideration many things that I have actually mentioned. But as you said, for me, let's say in the last few years, I have learned to use them and when to use them a bit more. So I don't feel that we should use them for every case, despite they're very nice and you feel very comfortable with them. As I said, they're very good view and the handling is perfect all the time. It still doesn't feel great for me that you need to throw them away after every procedure, mainly from the environmental factor point of view.
Same. The Flex X2 and P7, still I take P7 from Olympus or Flex X2 in initial go, and we have some difference in practice. Disposable scopes are reused in India. That's not correct, and that's a totally different topic. I know
that's different topic. Yeah.
Number two, if you are getting infections, some part of your practice suddenly gush of infections in 1 week because of the XYZ contamination, what is the protocol you follow? Generally, we stop the theater for 2 days. We reorganize the things, steroid sterilization, dry up everything, then restart. Some bug. This happens in India very commonly because our sterilization protocols may not be that stringent. What about your experience in large volume center? Suddenly gush of UTI will come.
Yeah, to be honest, I haven't seen many of these happening here, but there was one case where there were many cases in a row, as you said, and it was found that, of course, everything stopped for a few weeks and all the ureteroscopes were investigated. There were search in each of them with all the, I don't know what they do exactly, but they searched the colonization of them, and they found that over their sterilization process, they were put in the same sterilization of the of the scopes used for colonoscopy. So that was the reason of contamination. So they tried to avoid that from then on, and that problem never happened again.
Yeah.
To be honest, as I said, if you have a high-risk patient with diabetes, previous history of sepsis, probably there would be a reason to use a single-use scope, but everybody has different view in this.
Third question. Normally, 5 years back when volumetrics are used to come to us, you used to dust and we used to dust and we used to dust till the last particle, and whoever doesn't break the stone is a successful hero. Now, what we are doing is put it in a corner, if preferably in a calyx, break it fast in a large stone, then keep high frequency like thulium fiber laser and no technical skill, pop dust, and wait for 4 minutes, 5 minutes. If it is trapped in some localized area, unlike in pelvis, enough. And entire shift in 5 years is now nobody is showing that fine dust till the end. Okay, first half part when the stone is big, you cannot anyway fragment it. But as much as possible, fragment and put them in one place and pop dust. Where are we? There are even Monga and Traxer differs in that, and many of you people are also very experienced. If large stone volume is there, if you wanted to quickly come out, sometimes we come out in 25 minutes, 2 centimeter stone, TFL, keeping 1.5 watts and 10 hertz. What is your experience? You are also using Holmium high wattage laser.
Exactly. So I feel that with Holmium YAG laser, you can still start fragmenting your stone, so you reduce the initial volume. But as you said, there is a tendency to then put it in a calyx and do a pop dusting technique. To be honest, what I find is that sometimes with hard stones, you cannot effectively dust as much as with the TFL. So my tendency would be to still remove with baskets the bigger fragments and then dust the rest.
Recently, the flexible ureteroscope size is decreasing. Yesterday, one scope I have seen, I'm sharing today in Twitter. If you pass through the 9.5 French sheath, one more guide wire of 0.025 is going through that. That is 7.3 size, probably the smallest, named UseMed. No conflicts of interest. Tomorrow, if a 6 French scope comes, 6 French with 50 micron fiber, do you think that the access sheath roll may come down?
The role of the access sheath, that's a good question, but
6 French flexible scope, you can imagine it will be very, very small, and 50
it will be very
micron
small,
fiber will be sooner coming. Already I am using 150 micron fiber. 50 will be sooner coming from Russia. They are already on the way, Dimitri and his team. So what is your imagination about very small scope disposable with same efficiency?
Yeah, I mean, there will be the revolution, definitely, because there's already been a revolution with the 7.5, which means that 6 for sure will be welcome to the market and to the clinical settings. What I'm wondering is, it's true that it's smaller, and so you still have a good drainage through the ureter because the ureter is still patent, but sometimes you have very, very narrow ureters or narrow PUJ. So in these cases, you don't have a good drainage, and if you are inside the renal calyces for a long time, maybe your intrarenal pressure is still too high. So maybe in this case, the role of the access sheath could be for these specific cases when you need better drainage.
Also will decrease. Probably that is
will decrease and will be indicated for selected cases.
Yeah. Now, recently we have seen the rigid scopes, nephroscope, rigid cystoscope are also becoming digitalized, and small monitors are attached to it. I hope you understand. The disposable flexible scope is separate monitor is there. Same disposable companies are making already in India. Nephroscope has come, cystoscope has come. So the future of high cost HD cameras, except for laparoscopy, it can challenge, because the scope, ureteroscope, when you are handling in upper ureter, the monitor weight will affect your performance. Now, in
Yes.
that case, rigid ureteroscope converting into the digitalized, so that the small monitors, less costly monitors can be applicable to them also. Excellent vision. Excellent vision. No difference in usage. We are already using for nephroscope.
Wow, you're very ahead in India. I haven't seen this using for a nephroscope yet. I've seen the cystoscope, but which I guess you can use, and we're thinking to, but we haven't used yet for PCNL.
Yeah.
So it'll be interesting to see.
Because we have less strict rules in permissions. So we early release will be there. Way before in 2017, I am the first person to use thulium fiber laser after Russians in India. That's a different issue. Recently in a live workshop in Morocco, the Chinese surgeon has shown one small oval structure going into the kidney with all remote controlled, sitting inside the kidney, and then it's like too much imagination of technology. The laser, light source, everything is in capsule.
Wow.
Micro robot, and it sits on the stone, eats away the stone slowly with the control outside.
Where is our fun when we don't get fun anymore?
Yeah, so robotics also, people are saying these are the changes. Anyway, again, related to the same question, in 10 years back, Mihir Desai from US has tried the robotic technology, and it vanished for 8 years. From 2010 to 2018, nobody talked about it. Fortunately or unfortunately, last 2 years, again, this market has come into the picture. I feel 20 to 30 minutes with a disposable scope is not very difficult for manual handling. We can easily do it. Even in sitting posture, we can do RIRS. So the cost of that is around 1 crore rupees in India. I don't know how to convert it into maybe 1 lakh euros, something like that. Is it worth that? Does it stay robotic RIRS?
Yeah, that's a very difficult question. To be honest, I cannot see the place of robotic RIRS at the moment still. And I guess with all these topics about ergonomics, like studying about ergonomics and tendons and muscle workload and
you have
fatigue.
Already shown the picture, nice picture where electromagnetic signals are taken from the muscles, different muscles.
Exactly.
Yeah.
And it's been found that there is a lot of fatigue of surgeons with neck problem, arm problem, back problem, just because of how many procedures you do. But still, I don't know if this is enough to justify such an expense, to be honest.
You are such an excellent academician across the world, especially with your team. Honestly, with your commendable subject, reading about so many articles and quoting so many articles and reading day in and out, do you think that in RIRS, the temperature has ever, in the hands of poor surgeons also, have given very, very bad results extent of nephrectomy?
Yeah, this is a very interesting topic, and I don't think we know enough. What I can tell you is that I have never seen any damage that I thought could be directly related to temperature. But I recently went to a conference when I heard Saeed Bimhari from Saudi, and he showed some terrible complication caused by pressure. For example, coagulation of the renal pelvis, which completes scar of the pelvis. This was due to a very prolonged lithotripsy with no access sheath and high pressure and temperature. And I thought maybe we should know a bit more about it. But as I said, I don't think we know enough.
Last few questions, 2 questions. Lot of discussion. Even I'm strong favorite. 16 years I used prone PCNL. Now I have converted into supine PCNL last 3 years, and ECIR's role is significantly increasing. We have the multiple options, encrusted stents, multiple stones in the ureter and kidney. Totally different. Do you think that surgeons should be well versed with both during the training, both prone and supine? Because ECIRS is practically supine PCNL. Practically supine PCNL.
Yeah, it is. Yeah, I think.
Do you think the youngsters who are coming, should have some knowledge about supine PCNL also? Are you practicing?
Yeah, definitely. We do it, we practice it, and we don't do it for every case. We try to do it when there are specific indications that large stones, complex, different calyces and difficult to reach, like lower pole and upper pole, or difficult anatomies. And I think there should be a specific training, maybe fellowship training, not necessarily in the training, but for an endo-urological focused person, there should be a training in ECRS, yes.
My last question. Some ectopic kidneys, some horseshoe kidneys, some mal-rotated kidneys during RIRS, slight PUJ obstruction, doubtful will be there. Nuclear scan is negative. One small stone will be there. Not really symptomatic, but stone is 1 centimeter. Outflow doesn't come very well. You can't pass the access sheath across the UPJ. You can do it, but you have fear that once you touch that UPJ, which is not bothering, will bother in the post-op. These are, UPJ is not a defined term, but if the scope goes okay, if the water is coming out okay, if the water doesn't come out on the table, and stone is small, not big for PCNL, 8 mm, 6 mm, like that, 1 or 2 stones are there. Especially in ectopic kidney, this is a problem.
Yeah.
So what do you think Stent and do, or anything clue?
Yeah, I think you're right. Probably I would, well, here in the UK, we have long discussion with patients to sort of say what are all the pros and cons of doing the procedure. And if they're completely asymptomatic, sometimes we also give them a choice of surveillance. I know that there is a specific anatomy and there's high risk of complication. And if the stone grows, you don't have the option ureteroscopy anymore. But still, 1 centimeter is still a good size. And maybe the stone will be stable for years and the patient will never have any problem.
Right.
So I think it depends on the age of the patient and the presentation. But if it's symptomatic or we see that there is some reason for treatment, I would do a ureteroscopy and maybe leave a stent for a longer time after.
Great. So that finishes our talk, and I must appreciate the amount of the interest. One of the few female urologists who have gone into so much depth in endo-urology. What made you? Which year is a great turning point in your career to go into such depth in endo-urology? Who made you to really get so much into phenomenal academics? Phenomenal academics.
That's very kind, but well, it's just interest, really. I finished my training in Italy, and then last year my residency training, I discovered endo-urology thanks to my at the time the consultant who worked with me, whose name is Guigi. He's not very well known in academics, but he gave me all the tips and tricks and he let me do things. So I realized how satisfactory it is as an operation and how happier are the patient after. And so I realized that I want to do a fellowship in this, and I did it for a year with Professor Somani, who also gave me all the knowledge I have now and gave me all the tools to develop it. So that's how everything happened, really.
How many hours you people work for this academics? 12 to 16 hours sometimes?
Oh my God. Sometimes we work in the evening because we work full time clinically. So
apart from clinical, writing up a scientific paper is not easy.
No, it's in our own time. So sometimes in the weekend, sometimes in the evening. That's what we can do. We do what we can do. Yeah. Well, we have many colleagues that work with us.
Are contributing to the science a lot. The future generations will remember all this. At least I am making one video of this small thing. This YouTube link will be there. 200 people have watched. By tomorrow, 1,000 people will watch this video. This link will be there forever. Thank you very much.
Excellent.
Excellent.
Thank you very much for inviting me and for this nice chat.
Thank you very much.
Bye.